Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.
I'm going to talk about this poster number 1709, which is a presentation of a verified study, a phase 3 study of the hepcidin mimetic Rusfertide, also known as PTG-300, in patients with Polycythemia Vera. This is the study that is underway based on the outcome of the phase 2 open-label study with this particular medication. Now, Rusfertide is a hepcidin mimetic. What that means is it is acting as a hepcidin in the body of the person, and hepcidin is the marker and major player in the iron metabolism. As you mimic hepcidin activity, you would keep the iron inside the spleen or liver or lining of the GI tract, and there would be less iron for blood making. And less iron for blood making, meaning less of the production of the red blood cells and less of a need for phlebotomy. And phlebotomy is the primary way how we manage high red blood cell count in patients with Polycythemia Vera. So in the phase 2 study, the hepcidin mimetic Rusfertide, which is, by the way, given as injection under the skin once a week by the patients, was able, through this mechanism of action, to immediately, within 2 or 3 weeks, in great majority of the patients, eliminate need for bloodletting, or eliminate need for phlebotomy. So iron is not available for red blood cells, no need for phlebotomy because red blood cells do not grow. Very simple, straightforward therapy. And quality of life certainly may improve along the way, because when you have too many red blood cells in circulation, you don't feel well. Concentration issues, shortness of breath, fatigue, these issues improve. And therefore, today, I'm talking about this verified phase 3 study because through knowledge we gathered through the phase 2 open label study, we are very confident that this may be a new therapy for patients with Polycythemia Vera that need too many phlebotomies. And the blinded randomized study is underway. It's called verified study. Many of my colleagues ask about the real mechanism of action of the Rusfertide, because it's so much different than any other mechanism of action of any other drug that we have tried so far to treat the patients with Polycythemia Vera. Remember, Polycythemia Vera is clinically presenting with too many red blood cells. It can sometimes have too many white cells and the platelets. It can cause symptoms through circulation being affected, through inflammation that comes with the disease itself. Occasionally, it can have a big spleen, and we typically use in everyday management hydroxyurea, which is a chemotherapy that kills growing cells simply. We also may use interferon, which is biological agents that modifies the growth of the cells in the bone marrow, or ruxolitinib, which is a JAK inhibitor, inhibits the growth and inflammation in the body of the patients, and it's approved after Hydrea. But this particular drug, through being a mimic of a hepcidin, master iron metabolism protein in the body, have a completely different way of controlling what is the number one problem in PV patients, and that's uncontrolled red blood cell growth, a need for phlebotomy, and through that unique mechanism of action, as I explained to my colleagues, it works right away, and it's very effective, safe, and it seems improves the quality of life as well. The other question is, how is this going to compare to other agents that we use? And as I mentioned, we use Hydrea, interferon, and ruxolitinib. But this is different. This is a drug that can be used alone in people, Polycythemia Vera patients that require too many phlebotomies, 3, 4, 5, in 6 or 12 months, where the goal would be to eliminate that need and have a control of the hematocrit below 45 all the time, which is proven to decrease the risk of blood clotting and the risk of dying. Or it can be adjunct to a therapy that is already in place. There are many patients that are given hydroxyurea, for example, and you can control to some degree the white cells and platelets and the red blood cells, but there is still need for phlebotomy. We can add the Rusfertide to hydroxyurea as adjunct to eliminate need for phlebotomy. In fact, I think there are many patients like that are on hydroxyurea as a standard first-line choice that have not achieved that optimal control of the red blood cell count and need another agent to completely eliminate for phlebotomy and maintain hematocrit below 45%, a standard goal of therapy. The information from the phase 2 open label study of hepcidin is important to highlight the need for a better therapy of our patients, better therapy in terms of optimizing the care of our patients to prevent the thrombotic events, which are the leading cause of death in PV patients. Otherwise, patients with PV have a close to normal life expectancy, somewhere about 15 to 20 years, which for a 60-year-old typical age at diagnosis of PV, for 60-year-old would be close to normal. The clotting events are related to uncontrolled blood cell count and particularly red blood cell count. So developing a specific drug to focus on the need of eliminating phlebotomy and normalizing hematocrit with the possible improvement in quality of life, raise the awareness of what needs to be done for patients with PV. So even today, when we don't have results of the phase 3 randomized study to say, hey, this drug is so effective in what it's supposed to do, and it is now available for our use in everyday practice, not yet. But even today, there is that influence of that study on our understanding what is optimal care of patients with PV, and that is elimination of phlebotomy, normalizing hematocrit below 45% to decrease that thrombotic risk. Now, with much excitement, we are waiting for the phase 3 study to accrue all the planned patients and proper follow-up to be in place for us to learn whether we will have another approved drug for management of patients with PV. Remember, PV is chronic condition, and it will take some effort to prove a value of Rusfertide when it's compared to placebo. We need to accrue a number of patients and monitor them for a longer period of time, almost a year, for us to be certain that the phase 2 study results, a high response rate in eliminating phlebotomy and improvement in quality of life, is achievable in a blind and randomized way for approval to be given by the regulatory bodies in the United States around the globe. Now, my feelings are that this is going to be achieved, and with enthusiasm, we are looking forward to maybe a couple of years to have this drug available for our patients. The key takeaways from the whole concept of developing the hepcidin mimetic is that there are alternative ways of tackling the uncontrolled growth of the cells in the bone marrow. It doesn't have to be a chemotherapy, or it doesn't have to be a medication that may have some significant side effect. In the Rusfertide, we have what one may say a biological agent through a unique mechanism of action, mimicking what actually happens in the body of the patient, and with that providing a substantial response that is the most important benefit to a patient. So not only awareness of the goals of therapy is something that we gathered from following the story of development of Rusfertide. It is only about understanding about the biology of the disease and which factors contribute to its existence and persistence in the patients with these hematological neoplasms. So a discovery both in the biology as is in the clinical arena are the benefits of us following the story of Rusfertide, and hopefully at the end we will be able to provide this valuable therapy to our patients in everyday routine management. I would hope that everybody understands the ramifications of developing the alternative through different mode of action therapies for our patients with Polycythemia Vera, because there are patients that need a better, different approach in their management, not only that hydroxyurea or interferon or ruxolitinib are out there. There is a need for more specific, different medications, and I hope, therefore, that we will all endorse this particular study in terms of accruing the patients and doing everything we can to possibly prove this valuable therapy be good enough and significantly beneficial to our patients so that we can utilize it without much of reservations if that drug is approved in the near future.
Like, share, and subscribe here on Oncology Tube to get notifications when similar videos are available.